Hello everyone, in today's module we'll be talking about abdominal trauma. Alright, I know it's a huge chapter, a lot of organs, a lot of injuries to remember, but we'll try and simplify it very much. Alright, so it can either be a blunt abdominal trauma or a penetrating abdominal trauma. So in the first half, let's only concentrate on blunt abdominal trauma. So what we'll do is we'll stick to an algorithm, alright, and we'll follow that for almost all the organs, and that will be very easy for you to understand. So once a patient comes with history of blunt abdominal trauma, two things you're going to do if time permits. First is you give the patient 1 liter of IV fluid, and second you do a fast scan. Okay, these are the first two things you're going to do. Now there are other criteria that you need to assess before you categorize these patients, and the criteria is hemodynamic stability. First one. Second one is presence of peritonitis. Okay. So now based on this, if the patient is hemodynamically unstable or there is peritonitis, you are going to operate on these patients. Okay. Now let's assume the patient is stable. Patient is stable. Okay. If time permits, you would have done a fast scan in the first step. If time has not permitted you, you do the fast scan now. That means if the patient is so unstable, you don't have any time, directly you would have shifted him to the OT. Okay. Now if time permits, here you are going to do the fast scan. Okay. Now fast scan can either be positive or negative. Or it can be positive or it can be negative. Okay. We are more concerned if it is positive. Positive means there is some amount of bleeding or contamination, something that is going on. So you need to evaluate these patients further. So how are you going to do that? You are going to do that with the help of a CECT abdomen. Okay, you are going to do CECT abdomen. In CECT abdomen, two important things that you need to look for: where is he bleeding from? Okay, is it solid organ or is it from a hollow viscous? Because these are the only two things inside the abdominal cavity, right? It has to be either a solid organ or it has to be hollow viscous, like the intestine. Now, initially we told you if the patient is unstable or presence of peritonitis, you are going to operate. What does peritonitis basically mean? It is indirect predictor of a hollow viscous organ, correct? Because blood per se cannot cause peritonitis. Okay, if it's a solid organ injury where the patient has bled, bleeding initially will not cause peritonitis. Probably over a few days it can cause peritonitis, but if it is peritonitis, it means it is hollow viscous organ injury. So here if it is hollow viscous organ injury, what are we going to do? We are going to operate. Okay, simple. Now let's see the solid organ. Now solid organ, you need to see whether the patient has bled and stopped. That means has the bleeding already stopped, or is there active bleeding? How will you assess this? In the CECT abdomen, it's a contrast enhanced CT, so we would have given an IV contrast. So that IV will travel through your circulatory system or your vascular system. Then what will happen? If it is bleeding, you will see the contrast escaping from the blood vessel. Alright, wherever there is an injury, contrast will keep coming out. So this is called as an arterial blush or a blush that is seen on the CT scan. Alright, so if the patient is actively bleeding, they will have a contrast blush, also called as arterial blush. Okay. If nothing is there, that means the patient has already bled and the bleeding has stopped. So for these patients who have bled and stopped, you are just going to observe. Okay, nothing special to be done, observe and manage them conservatively. But if they are still actively bleeding, you have to stop the bleeding. First, try minimally invasive methods, that is angioembolization. Because whatever we are doing so far is in stable patients, correct? So if he's stable, try minimally invasive, try angioembolization. That means they'll make a small cut in your probably a femoral vein, go inside, release certain coils, small coils, okay? So these coils will go and sit at the site of bleeding and they'll block and they'll stop the bleeding. So this is the preferred choice at that point of time. Somehow these might not be active or these might not act that well all the time. Okay, so it can fail. If it fails, okay, if it fails, you're going to operate on these patients. Okay, so let's just summarize this chart again. All right. So whenever the patient comes to you with blunt abdominal trauma, first thing you're going to look for is hemodynamic stability and presence of peritonitis. If it is present, you're going to operate. If it is absent, you're going to evaluate further. This is how the question will be. Patient comes with trauma, you have resuscitated with fluids, BP from 90 has fallen down to 80 millimeters of mercury. That means hemodynamically unstable. Do you operate or do you do CT scan? Answer is operate. Now the second question, similar history, 90 by 60 BP, you have resuscitated, BP has picked up to 120 and patient is stable. Do you operate or do you do CT scan? Answer is CT scan. Alright. So this is how the questions will be. So if you understand this algorithm, answering those questions will become extremely easy. So like I said, if the patient is stable, if you have not done a fast scan already, do a fast scan. If it is positive, go ahead with CT. Now in the CT, you will get to know whether the patient is bleeding or is already bled and stopped. If he is bleeding, you are going to go ahead and do a angioembolization. If that fails, you are going to operate. Alright. So this is the algorithm that we are going to follow for almost all the organs in the abdomen. Okay. So first, let's look at a few investigations. First and foremost, the most important one that you guys need to know is what we call as a fast scan. Fast scan stands for focused assessment of sonology in trauma. Alright, that's what FAST stands for. Now in FAST scan, what do? You're going to put the probe in 4 areas. Right upper quadrant, epigastrium, left upper quadrant and pelvis. Why these 4 areas? Simple common sense. Okay. Now the most important solid organ injuries, which are they? Liver and spleen. That's why right upper quadrant, left upper quadrant. Pericardial tamponade is extremely dangerous and the patient can die because of it. That is why epigastrium, because you are trying to look for pericardial tamponade. Why not the other areas and why only in the pelvis? Because when you are standing up, pelvis becomes the most dependent area. So the idea of fast scan is just to tell you if there is some injury, not trying to tell you where it is from, what grade it is. That is not the idea. Idea is to tell if there is an injury. So anywhere in the body, if there is bleeding, the first thing the fluid is going to get collected in a standing or a upright position is the pelvis. So pelvis, you're going to put a probe. If you find fluid or if you find some collection there, that means there is some injury, there is something going on in the abdomen. That is the idea of a fast scan. Okay. First probe in the right upper quadrant, you're going to look for liver, right paracolic gutter. Okay. Second probe in the epigastrium. Here you are trying to look for pericardial tamponade. Third, in the left upper quadrant, you are looking for spleen and perisplenic areas. Fourth one is the pelvis. Okay. So collection or injury from anywhere in the abdomen will come and sit in the pelvis. Alright. So this is the fast scan. What is the disadvantage? First and foremost, it is operator dependent. What does this mean? It depends on the experience of the user of the probe. It is like the difference between me cooking and my mother cooking. I know how to cook, but I know that I'm not as good as her. So when I'm trying to cook, I may make a few mistakes. So the same thing, an inexperienced person holding the probe can miss out on important findings in the fast scan. Alright. Second, it is not very reliable if there is a lot of air either in the skin or inside the abdomen. So in the skin, if air is there, what do we call it? We call it as subcutaneous emphysema. And inside the abdomen, it is air-filled bowel loops. Okay. And the last one is, it can only assess if the fluid is more than 100 ml. Okay. So what do I mean to say? That less than 100 ml collections can be missed. Alright. So this is about the fast scan. Next, you have an addition to that is called as an extended fast scan. Extended fast scan, where apart from these 4 areas, that is the right upper quadrant, epigastrium, left upper quadrant and pelvis, you also put the probe in the right and the left anterior pleural window to look for pneumothorax. Alright, they are called as the anterior pleural window and you are trying to look for pneumothorax. Okay, so this is called as the extended fast. It's just an addition to it.